Today, we have a special privilege of having an external speaker, Dr. Aws Almufleh. He's a rising star within the echo field in the country. It's very hard not to see him when you go to the CSE meeting or the Canadian Heart Failure Society and also the CCS meetings as well. He's actually been involved in all these societies and contributing a lot. He's an assistant professor of medicine at Queen's University. He specialized in heart failure and advanced echocardiography. He completed specialty training at Ottawa Heart Institute, the Brigham and Women's Hospital, Harvard Medical School for heart failure, and also spent some time in Vancouver General Hospital for echo. He is currently the physician lead of the heart function clinic at Kingston Hospital or Kingston Health Science Center, and is leading several projects on optimizing heart failure management in the community and establishing integrated care pathway for heart failure in Kingston. His other areas of interest include echocardiography, medical education, and he is also the recipient of a CSE CREATE grant to help develop national echo learning and assessment tools. So without further ado, I'm going to pass the baton to Dr. Almufleh, and we're privileged to have him as our guest speaker today. Please go ahead.
Thank you so much, Chiming, for the kind introduction and for inviting me to speak. We really enjoyed the collaboration between our centers. We like having St. Michael's, phones on speed dial when we have elderly adults whose the surgeons decline, and we know there may be something Neil Pham and his group and you guys can do at St. Michael's. So we appreciate that. I will be talking about echo utility in the diagnosis and management of patients with cardiac amyloidosis. And these are my disclosures. At the end of the session, I hope participants will be able to review clinical diagnostic red flags of ATTR cardiac amyloidosis, to review echocardiographic findings of cardiac amyloidosis, and discuss potential avenues to shorten time to diagnosis and to treatment initiation, and how an iterative quality improvement cycle can help. I will not be talking about the treatment of cardiac amyloidosis in details, nor will I talk about how to rule out amyloid light chain. I think this document that was published in March of 2020, apparently the same month where these rounds were started, suffices more than all what the cardiologists need to know about how to diagnose and manage cardiac amyloidosis. They go into details about the algorithms, and I find it quite useful, and I use it in clinical practice. Now, every time I work with a resident or a student and I ask them, did we consider amyloid? You see them becoming anxious, and I don't blame them, because I remember in internal medicine residency, when you hear amyloid, you think of so many subtypes. AA amyloidosis, and the one that comes with dialysis, and what about Alzheimer? I heard something about amyloid. When it comes to the heart, there are two subtypes of amyloidosis that are very relevant to the echocardiographer and the sonographer. We think of amyloid light chain, and that's blood cancer, very poor prognosis, median survival 6 months after diagnosis. And then there is ATTR amyloidosis. And the way I explain it to my patients is that I say, the liver in our bodies is a factory. It's like the factory that manufactures, that makes most of the proteins and the vitamins and the hormones that we need. Now, for the liver to transport these proteins to other organs, it needs to put them on transport proteins or trucks. And in your case, these trucks are defective. They fall apart. And when they do, the small parts that are components of this are called amyloid, and they're very sticky. They stick to the heart, and they cause the heart to be stiff, sometimes even cause it to be weak, and patients start accumulating fluids, We call that heart failure, but they can also stick to the place in your carpal tunnel, and they cause numbness in the hands, and that's where people have carpal tunnel syndrome. Can also stick to the back and cause spinal stenosis. People get back pains. Can stick to the nerves and cause numbness in the hands and feet, and can also stick to the kidney and other organs. And the importance for patients to know, all about this is that the diagnosis of amyloidosis required several tests, and even especially in the past when we had to do a biopsy to qualify for the treatment. Patients are not going to go for a biopsy unless they truly understand what is going on. And even now, for the PYP scan, the nuclear scan, the test takes 3 hours. They do images and then they repeat them again 2 hours later. So for patients to actually go through this, they really need to know what is going on and why do they develop these symptoms. So as we discussed, it's a multi-system disease and can involve many organs. Now, the most common though, and that is common to the relevant subtypes for the heart, are diastolic dysfunction and HFpEF. This happens in both AL and amyloid and ATTR amyloidosis, carpal tunnel syndrome, patients with wild type amyloidosis. These are the patients that have ATTR amyloidosis, but with no identified genetic mutation. We call them wild type. Can also have biceps tendon rupture. Biceps tendon rupture. They call this the Popeye sign. And then there are things that are more specific to AL amyloidosis. They're more likely to have small fiber neuropathy and autonomic dysfunction and hepatomegaly. Now, is this very rare? Or is it a zebra? And I argue that if you look at the prevalence data, that it is actually not that rare. When you look at statistics from the United States, it's kept, I would say, a bit more comprehensive than what we have here in Canada. They estimate 6 in 10,000 of the US population have cardiac amyloidosis. 2 in 10,000 have that in Canada. And when you look at a select patient populations, the ones that we see, there's actually a lot more that I think have it than we have recognized. There are studies that were done in autopsy studies, patients above the age of 80, when they did autopsies on them, and they found 1 in 4 had some amyloid staining in their heart. Now, it doesn't mean that they have developed heart failure. It also doesn't mean that they would have developed heart failure in their lifetime, but it just tells you how prevalent the accumulation is. It also hospitalized patients with HFpEF above the age of 60, 13% of whom, 1 in 8, likely has cardiac amyloidosis. What about TAVI? Your center does a lot of TAVI, and 16%, up to 16% have cardiac amyloidosis. Patients who are presumed to have hypertrophic cardiomyopathy, about 5% actually have cardiac amyloidosis. So here we'll ask a question, and maybe if I may ask, if you want to unmute yourself or even just type your answer in the chat, which of these conditions are most specific for ATTR cardiac amyloidosis? And the emphasis here on specific. And the one that I have reviewed was from Sweden, where they looked at about 1,000 patients who were diagnosed to have amyloidosis cardiac amyloidosis between 2008 and 2018. And they have national health system like we do. And so it's easy for them to capture those patients, and they have recorded their data. And then they looked at an age-matched group. And in their analysis, they found that if you have carpal tunnel syndrome, unilateral or bilateral, it doesn't have to be bilateral, or bilateral, you're more than 6 times more likely to have had cardiac amyloidosis. AFib and atrioventricular disease is also prevalent in patients with cardiac amyloidosis, but it is not as specific in their study. And the same study also benefited from them recording the data longitudinally over time. They asked the other question is that when you identify one of these red flags, how long does it take for those patients to be diagnosed, not to develop cardiac amyloidosis, but to actually have that diagnosis made. And carpal tunnel syndrome, about 6 years. About 6 years. Atrial fibrillation and other cardiac manifestations, about 3 years. And then when they develop heart failure, then it's shorter afterwards. The role of echo cannot be overemphasized, right? Most patients, at least in our center, that were diagnosed to have cardiac amyloidosis, the suspicion was raised based on an echo that they had. And some of them, the echo was not even done for heart failure. So echo role is very important. What do we look for in an echo? This is not new information for you guys. The biventricular wall thickening, that scintillating or speckling appearance of the myocardium, atrial enlargement, pericardial effusion, diastolic dysfunction, and restrictive diastolic filling. Patients can have some degree of systolic dysfunction. So it's not true that it's always HFpEF. And in fact, depending on the study you read, about 30% will have a reduced or mildly reduced ejection fraction. Thickening of the valves, of the interatrial septum, and apical sparing pattern on on strain. Now your center, you do a lot of TAVI. We do that too at Kingston Health Science Center. And some of those patients, when you read their echoes, it's done post TAVI. Nobody's asking you about amyloidosis, but they really look, concerning. And this study looked at 9 observational cohorts and compared patients who had AS versus those who had AS and cardiac amyloidosis, and try to identify what are the features that are most prevalent in each of these categories. And you could see them in the slides right here, but I categorize them into patients that have cardiac amyloidosis in addition to aortic stenosis, often do not have severe aortic stenosis, or their gradients may not be in the severe range. But what is more striking in those patients is that their wall thickness is very high. And they have evidence of diastolic dysfunction, more impressive diastolic dysfunction. When you look at patients with aortic stenosis, their LV and RV function is preserved, in fact, better than patients who also have cardiac amyloidosis, not surprising, and the aortic valve gradient is higher. Now, in all the other features, there's a lot of overlap. So none of these features is unique. It's just something to think about when you're considering, is there an overlap, or is this just plain old aortic stenosis? And my approach is, when in doubt, just do the PYP scan, right? Do the test, of course, ruling out AL and doing the PYP scan. And because in my mind, it's a non-invasive test, relative non-invasive test. And if the patient has it, that has impact on their treatment. What we do with their aortic stenosis, it can change. TAVI is more recommended. But even if they didn't have it, we learn, right? As a lab, we learn. We learn, what is it that had been unique about that patient. So in the next few slides, I'm going to show some echoes, and we can, and I will ask if you guys can put in the chat if you think this patient has or doesn't have cardiac amyloidosis. So this is an 80-year-old man with his echo request being edema. Echoes being done for edema. So that's his parasternal long axis view. Systolic function doesn't look too bad. This is the parasternal short axis view, focused on the aortic valve, thickened, but I think opens well. Now this is the apical 4-chamber view. Again, LV systolic function is okay. Excuse the first beat, there was an ectopic beat before that one. Now, when you look at the E over E, E is similar to A, and E the velocity is 94. E prime lateral is about 8. The medial is 9. Tab C is preserved at 2.5, and these are the numbers at the end of the report. So in the chat, we can see the first 2 or 3 answers. Do you think this patient does or does not have cardiac amyloidosis? I'll show the 4-chamber. Oops. Yeah, it doesn't play when you go back. Yeah. Yeah. What is the prevalent answer, Qiming?
Does the person have carpal tunnel syndrome?
I don't know, because here
Not,
we are limited on what is in the indications, and we don't know what their ECG is. This is all we have.
no, I'm just kidding. Well, it is not our most classical looking
I agree. I agree.
amyloid, if it is, but we cannot entirely rule it out. But I don't think this is like your typical version of it.
I agree. I agree 100%. And that patient, in fact, did not have cardiac amyloidosis. Don't worry about the poly everywhere. I tried to set it up. It was complicated. I'm not like Qiming. So I said, we'll just do the chat instead. No, you're absolutely right. This patient did not have cardiac amyloidosis. And purposefully in the beginning, I said, do you think this patient has it? I didn't want to say, could this patient have? Because as echocardiographers, we always have that standard statement of, well, this cannot be excluded. Or so I was trying to say, even if we're not sure, we can guess and see. This different patient, though, EE, is 76 years old, and the indication, the requisition was lost. We don't know what happened to it, but there was increased troponin, and the sonographer did it in mind thinking for LV assessment. So that's the personal long axis. This is the personal short axis view. Aortic valve is a bit thickening, maybe some mild restriction. Now you're looking at the 4-chamber view, maybe tiny effusion around the right atrium. LV systolic function is normal. Now in the E over A, or the Doppler, E is 74, A is 72. Depending how hard you look, could there be an L wave here? Small, I can't, it cannot be ruled out. E prime lateral is 6.8. The tab C is 1.8. The medial E prime is 4.6. So diminished medial and lateral E prime, preserved systolic function, dilated atria. Could this do you think this patient has cardiac amyloidosis? So what do you think, Jim?
Looks like it has atrial fibrillation. So that's one of them. And then you have biatrial enlargement. There's also small pericardial effusion. There's also some mild aortic leaflet thickening everywhere. Although the wall is not your classic one that is like really thick and sparkly.
Right, and the walls here are, you're talking about 1.2 centimeter, 1.3. So it is increased, but is it not 15, 16 millimeter? But you are correct, though, that there is a lot of features that suggest that this patient could have amyloidosis, and in fact, this patient did have cardiac amyloidosis. It doesn't have, and the whole purpose of me showing these cases is that I hope that we have passed the stage where we can only pick it up when it is striking, right? Meaning like clinically. And I think that we finally now are starting to see, okay, what is the milder stage? How can we detect those before they deteriorate and get worse? Are we good for 2 more cases, Qiming?
Sure. I need other people to be a part of this as well. So please put in your thinking and your response into the chat. We'll monitor that.
This one is an 87-year-old man. He is short of breath, has CHF, and has mechanical aortic valve replacement. So here we see the shadowing from his mechanical aortic valve, the short axis view. lots of TR. And, initially when I first saw this, I'm like, oh, severe biatrial dilatation, it's got to be amyloid. You also see that the walls maybe not that thick. E velocity is high. We don't have A because he's in atrial fibrillation. Interestingly, the E primes are preserved. Borderline TAPSE. The E primes both were preserved. So here, I debated a lot about this one. I'm glad they ended up doing the PYP scan because, like I said, if it is there, we can help the patient. If it's not there, it helps us. It helps the lab, and this patient did not have a cardiac amyloidosis. I think one thing that was sort of it makes you suspect it is that the wall thickness, there was wall thickening, but also this patient has aortic stenosis for a long period of time, so those patients can have LVH. The final case is quite interesting because it is for a 71-year-old man who I looked after at the ward when he came, and in the first admission was a heart failure exacerbation with 2 days of diuresis. He became euvolemic, was about to send him home. This was his echocardiogram. And, I must admit, I read this echo. It didn't strike me as cardiac amyloidosis. I didn't mention anything about it. And the E primes were diminished. That is true. The lateral E prime was 6. The medial was also 6. The strain was reduced and maybe relatively spared, but no, there was no striking feature. So I read it and did not mention amyloid in the report at all. The same patient came back 1 year later. He's 72 years old now and now has biventricular dysfunction. And this is his LV. Look how thicker it got in 1 year. In 1 year, aortic valve is thick, and now we could see the scintillating, appearance and the restriction. This is the RV inflow. You always, look at the subcostal to look at the RV wall, but this is quite impressive, even in the RV inflow. Diminished TAPSE as well. E primes are diminished, and apical sparing strain. And now it's minus 6.3%. It used to be 14. Now, many of you who treat patients with amyloidosis, clinically would deduce that it cannot be ATTR, right? It's not that fast. It doesn't advance. It doesn't progress that fast. So unfortunately, this patient ended up having AL amyloidosis. The LV systolic function had diminished. He had biventricular dysfunction and had anasarca. He was not a candidate for chemotherapy. Even with the benefit with respect to scope, it would still be hard to diagnose the first echo. But I think this is a case that reminds us that, there's a lot at stake if we can diagnose those patients early. What did I learn from this exercise? Identifying those patients who have cardiac amyloidosis and then, going back and looking at their echoes. One, the standard statement is of severe biatrial dilatation. It's not always severe, right? It doesn't have to be severe. This patient, 34.9 cc per square meter. All you have to do is just be above the age of 70 and you'll have an LA like this. So it doesn't have to be severe. What about the wall thickness? Does it have to be 15, 16? No. This patient had septal wall of 12, posterior wall of 13, especially when you see thin men or elderly ladies, elderly small ladies. They're not going to have a wall of 14, 15. So keep that in mind, keep an open mind. The mass index, right? Does it have to be 150? No, this patient had 112 mass index, so that is not, it shouldn't be used to exclude. What else? The size, the LV size, usually normal, sometimes small, maybe mildly dilated. It should not be severely dilated. When it is severely dilated, think twice. It's probably not. What about the wall thickness? It has to be increased. It has to be increased. Maybe not at 15, 16, but the wall thickness should be 12 or more. If it is low and the patient has severe eccentric hypertrophy, usually those patients have very dilated and big cavities with thin walls. They still have a hypertrophy because there's a lot more wall in that dilated chamber, and therefore that shouldn't be used to suspect cardiac amyloidosis. If the individual walls are not thick, it's not cardiac amyloidosis. The atria usually both are dilated, and verify the measurement. Because when I go and read the report and then I look at it, and some reports I made myself, but I go back and review how the atria was measured, then I find that, okay, if I had looked at it and remeasured, probably would have been dilated. Looking at old studies, we get that privilege, and not many modalities have that availability. ECG, sometimes the ECG is not small voltage, but it's small relative to the thickness that you see on the echo. Strain is helpful, but also how strain is done is important, right? We have the obligation to report strain, but if it is not well done, some clinicians may use it to exclude cardiac amyloidosis, and that really should not be the case. So, and the significant delays that we see in cardiac amyloidosis diagnosis is not a Queen's thing. This is universal. I think this study looked at 23 papers and reviewed 620 patients who had the documented, when were they first seen and when the diagnosis was made, and it can be up to 7 years of delay. And most of the time, we're really just looking at the tip of the iceberg, barely diagnosing them at the stage when they develop heart failure. But ideally, we should try to aim to explore, other populations, like patients that have aortic stenosis, maybe atrial fibrillation. I know Dr. Ong is working on a project to start to identify them in TAVI patients. And many patients have seen 2 or more cardiologists before the diagnosis made. And why that is relevant is, there's treatment now. This is no longer an incurable disease. Just organize your matters. There's nothing we could do. No, there is something we can do. Even for AL, there are new chemotherapy, including daratumumab, that has been shown to improve their outcomes. And for ATTR, there is the tetramer stabilizing drug. I think most of us are familiar with that, tafamidis. What I like to highlight, though, if you see the ATTRACT trial, ATTR ACT trial, that established the benefit of tafamidis, it showed that the first 15 months after you start the treatment, the curves overlap. Thank goodness they didn't stop the trial for futility. But then when you wait longer, they start separating. So when the urgency of diagnosing those patients is that from day one, when you diagnose them and from when they take the drug, their benefits actually will not show until a year or a year and a half. So that's the importance. And then when you look at the long-term extension, so they did their trial, finished at 30 months, New England Journal publication, people were very excited. And then they said, we'll take the placebo arm and now we'll give them tafamidis. And the same thing. So in the trial, 15 months, no clear benefits, and then the benefits started. The same thing here. So in the first 15 months after they gave the placebo arm tafamidis, the tetramer stabilizing drug, their curves with the extrapolated placebo was very similar, and then started to separate. What is most important is that it never equalized, right? You give it late, you're not going to derive the same survival as patients who were started 30 months earlier. So what happens at Queens or here at KHSC? Well, we have delays, and we have identified delays even after amyloid was suspected. Even after amyloid was suspected. So we've seen, in looking at our QI project, looked at previous patients. This is an example: an 88-year-old male, EF of 49%. 2017, the echo suggested they could have amyloidosis. At the time, I think the thought was, I'll exclude AL amyloid, and that was done. And then the patient was stable and he was discharged out of the heart function clinic. They were referred in February 2022, and that's when PYP scan was organized and they started the treatment. Another example: a patient with who's 81 years old, has HFpEF, whose echo suggested that they may have cardiac amyloidosis, and cardiac MRI, it was suggested that a cardiac MRI is done with a delay, took about a year, and then they had their PYP scan and the tafamidis was started. Another example, very similar. Amyloid was suggested on the echo in November 2021. MRI was ordered in May of 2022. Took about a year, maybe 9 months. And the MRI said, oh yeah, I think the patient has amyloidosis. A PYP scan was done 3 or 4 months later, and then the patient was diagnosed. So as you can see, in the previous cases, we're talking about 4 or 5 years of delay after developing heart failure. We don't even know, how long the patient had their carpal tunnel or their other symptoms. So the status before the QI, we had at the time when I joined, we hadn't been starting the treatment locally. Patients were being referred, and it was the wait time was long, and patients didn't really like the drive. We published the first iteration locally of how to manage cardiac amyloidosis, and it still is underdiagnosed and underinvestigated. At the time, in 2021, some providers were not aware of the existing treatments, and so they thought, what's the benefit of making that diagnosis? And this is the document that we shared about when to suspect it, how to rule out AL, imaging to confirm ATTR amyloidosis, genetic testing and how to do it, how to apply for drug coverage. It's a lot of paperwork, and it's important to guide people. And management. How do we manage and how do you use tafamidis? And so the goals of our QI project was, we wanted to build a local database of patients with suspected or confirmed cardiac amyloidosis. And I add suspected because it's the point that I tried to indicate earlier, is that patients who you think may have cardiac amyloidosis, you end up doing a PYP scan. If they don't, I find them to teach us really the most. When you look back and you can identify some unique features. We also try to map the patient journey from heart failure diagnosis to getting their echo, and that can happen before, of course. And then when the echo suggests that the patient may have amyloidosis, how long does it take for the PYP scan to happen? How long does it take for a cardiologist to make the referral to the heart function clinic and the diagnosis confirmed and treatment started? And we'll try to identify factors for delay at each stage. And this sort of combines my passion about heart failure with quality improvement and echocardiography. So I find this QI quite fulfilling. We have about 71 patients. 34 have cardiac amyloidosis. 14 or 15% females, which is consistent with other studies. Most had family physicians. Only half had cardiologists outside the heart function clinic. And you could see the prevalence of other features. We then compared those who had positive versus negative PYP scans in terms of their echo features. And not surprising, positive PYP scan, the thicker walls, posterior walls were thick as well. The A velocity is diminished. The A velocity is diminished. And that's not surprising, right? Those patients, even in sinus rhythm, they can develop a LA clot because they have a diminished atrial activity. And you'll find some providers recommend doing a TE for patients who have AFib and they have amyloid, if you want to cardiovert them, even if they have been compliant with their anticoagulation, because some of them can still develop a clot. It hasn't made it to guideline recommendation, but it is something that people have considered. What about TAPSE? TAPSE is, in general, amyloidosis, you have less preserved RV function, and the global strains, of course, worse in patients with cardiac amyloidosis. So in the beginning, at the baseline, we wanted to calculate these intervals. So how many echoes does it take to raise the suspicion about amyloidosis? And actually here, at baseline, we had about 3, average of 3 echoes the patient has before amyloid is then suspected. Now, from the time amyloid is suspected to the time they get the PYP scan, about 8 months. From the time they are seen by the cardiologists, and it depends. Some of them they've been seen for an NSTEMI, or so it's really any cardiologist seeing them. It can take many months before they get referred to the heart function clinic. And when they get referred to the heart function clinic for the time to make the diagnosis, that's about 8 months. So what are the interventions that we did to try and address the delay at multiple stages? One was educational sessions. So we had grand rounds, some dinner events, community cardiology talks. They see a lot of volume of those patients. Many are elderly, some have amyloid, so we did that. And also some rounds for our cardiology trainees. Tried to streamline the PYP ordering, and we had reached that stage where our wait time locally was very long. So we collaborated with the radiologist in Belleville who do PYP scan with SPECT, so at the standards required, and they have been taking some of our patients. Their wait time is 1 to 2 weeks. We collaborated with hematology colleagues, because when you suspect cardiac amyloidosis, you have to exclude, the blood cancer, the AL amyloid, and many patients have MGUS, so the monoclonal gammopathy of undetermined significance. They have this protein that is really not doing any damage, and about 40% of people that have ATTR amyloidosis also have that one. So you need a hematologist to clear the patient and say, no, that's not AL, you're fine, go ahead and treat them. We also made a coalition with amyloid enthusiasts at our center. So we had neurologists, 2 hematologists, radiologists, pathologists who also read our genetic testing. So they have been quite helpful. And we tried to offload the heart function clinic. At some point, the wait time at the heart function clinic was about 2 to 3 months. And so for those patients, we had diverted them to be seeing me at my general cardiology clinic so that we can then start the treatment. What was the impact of these interventions? On average, 3 echoes before the intervention, now about 1.5. So most patients would have just 1 echo that suggests their amyloid, some 2. The PYP scan, the time from when the echo suggests amyloidosis, usually within 1 month to 3 months, patients are getting their PYP scan done. Cardiologist visits to heart function clinic time has declined, and at the heart function clinic, when the diagnosis is suspected, then the treatment initiation is quite fast. Now, we don't see many positive p-values. It was a small sample size. We are still collecting data, but it does help us to understand what are the areas that have been helpful. Now, we also ended up with a wealth of data where we know what the echoes showed. We know what the clinician thought. We know what the echo report said. And then we asked ourselves, what is the implication of how the echo indication is written and how the echo is reported on clinicians' actions? So we looked at the echo indications, and we found, thankfully, that if amyloid is written in the indication or the history part, all patients get strain, and most patients would have amyloid written in their report, saying, it's suspected or no evidence or no suggestive features. We also looked at what if people just say HFpEF, not even amyloid. Most patients still get their strain, which is quite reassuring. That's how the indication can affect. What about the impact of the echo report? So if you read an echo report and you say nothing about amyloidosis, on average, it takes about 7 months for those patients who have amyloid to get the PYP scan done. And that usually is people are suspecting because of other clinical features or themselves are echocardiographers, so they go in and read, or general cardiologists will go in and read the echoes, look at it themselves and suspect it. What if we say general terms like, this patient has unexplained LVH, or their blood pressure is normal, but they have LVH. Or if we say, consider infiltrative cardiomyopathy or consider amyloidosis, it usually takes about 5 months to get the PYP scan. If you are specific and you say PYP scan is considered, then that's 4 months. And if you say cardiac MRI, it actually takes a lot longer. And that's an institutional thing. It won't affect you guys. I'm sure you can get your MRIs in a month or two, but for us, it takes about a year. So if you do suggest cardiac MRI, it means most clinicians would do it, wait until they see the results, and then, the patient has may have cardiac amyloidosis. MRI cannot confirm the diagnosis, right? It cannot confirm the diagnosis. It is not essential for the diagnosis of cardiac amyloidosis. And so my practice is that if I suspect it on echo, I'm going straight to the PYP scan and, of course, excluding AL amyloid. Now, we found an interesting phenomena, and I would like to hear in the discussion section what you guys think. But we found that after we initiated several educational sessions, and a lot of it happened before April of 2023, and actually one was really just the beginning of May. So after that, we saw a few months later, maybe 2-3, we saw a spike in the negative PYP scans, and this can become an issue because when you have a lot more testing of PYP scan for patients who have features that really shouldn't be tested, like a patient with a thin wall but has eccentric hypertrophy, you are at risk of getting false positive PYP scans. And if that happens, that has some implications. It also now has changed the PYP scan wait time. It used to be about 6, maybe 8 weeks, now 3 to 4 months. And you could miss AL amyloidosis. So if someone, educated now, I need to detect all the ATTR, and if they're not careful and they're not ordering the AL workup, that can become an issue. I'm not proposing that education is not good, but I think that we need to emphasize education and continued education. You really want to maintain that. You really want to appreciate the heightened awareness, but provide continued support on how to guide community and academic physicians. One thing Sharon Malvey talks a lot about is the role of echo consults, in that we're not just reading the echoes, we're not just reporting the images. We can go further and say, this patient may have it, suggest that you do the PYP scan, rule out AL amyloidosis, so that we can guide the clinicians, not just mention that in the report. You look online, you look in PubMed, lots of papers looking at scores, and we'll put all these risk factors together, and then patients who have all of this very likely to have amyloidosis. What is less done, though, is that who are very unlikely to have amyloidosis. What are the features that will make amyloidosis almost impossible? And the importance of this is that if you have those patients, one, you can really consider not proceeding to test them once your algorithm is validated. But two, you can still test them, but triage wisely. Patients that are likely to have amyloid should have the priority to get their PYP scan and to start their treatment. So the key messages I have for this is cardiac amyloidosis is underrecognized, is also undertreated. There is important role of the echo lab in enhancing detection of cardiac amyloidosis. Wording of the echo indication, but also the report, can have important implications on clinicians' action, and continued education is crucial. And I add here, continued education and support is crucial to avoid unintended consequences of heightened awareness of the disease. I would like to acknowledge my research team, to research assistants Drew McLean and Rebecca Wood, and our residents who have been, really volunteering in this project and working some weekends to collect the data. Connor Sheridan and Kirsten Leckie. And I'll stop for questions.
So once again, thank you, and congratulations on all your work. And we definitely can feel your passion about improving the delivery of care, true to one of the missions that you have. And also, we also learned that amyloid is a protein condition which has many shapes and forms. And the classic echo that we used to present in the echo rounds, to like thick wall, sparkling, biatrial enlargement, leaflet tenting, leaflet thickening, small pericardial effusion, are the ones that we learned when we grew up, but those are pretty much the late stage ones that we're going to pick up. So if we only pick up the late stage, we're missing a whole bunch of things early on and miss the opportunity of intervening early. So I think those are the message I get. And let's see what, if there are any, I have a question first, and then I'll see if other colleagues have questions. So we all know that doing everything these days is a team sport. So whether it's structural heart or other conditions, amyloid certainly is one. What was your experience of tying together the hematologists and the neurologists? Because obviously you need a multi-team approach to this problem rather than just being, a cardiologist. So what's your experience like in your institution, and what are some of your, thoughts about how to improve in other institutions?
Yeah, thank you so much, Jiming. I really like the take-home messages you pointed out. Tells me you didn't, take a nap during the talk, so that was great. For hematologists, I would say they are overwhelmed, and especially in our center, they get consulted for everything. Yeah, I feel for them. I think what we did is that we got together and we talked about amyloidosis. We even did a grand round that was multidisciplinary. So she was, her name is Dr. Monteith. She joined us in the rounds, and she gave the how to rule out AL amyloidosis. But they also provided us with the e-consult service. So this service, where they really don't have to see the patients, because with MGUS being so common in our patients, it will take them too long to wait until they see all of them. Most of the times right now, you can send that e-consult, you get the report within a day or 2 days, and most of the time they say, this patient very unlikely to have AL. There are two where they needed to see them in person, but that makes it faster for them to see because now they know them, and also it is rewarding to them because they get to remunerated for their time, as opposed to being bombarded by emails. Hey, I want to start tafamidis. Is this amyloid? Really, e-consult I found very useful. For the neurologist, Dr. Michelle Melanson, who's the chief of neurology here, has been quite supportive, I would say. And the reality is the overlap between neuropathy and cardiomyopathy. I'm starting to, see the prevalence of that overlap. And some of my patients, they say, you're talking a lot about shortness of breath and leg swelling. I have none of that. My problem is my numbness is killing me. I can't walk. I have a lot of balance problems. So we have actually been very lucky to have cooperative and supportive neurology team that have been seeing those patients within a month or a month and a half. They do EMGs on every patient they see, and then they start the management for those patients.
Yeah. One more questions for me. As an Echo Lab director, obviously we want to make our Echo protocol very parsimonious and not to be like overextending our colleagues. Question: if you see walls that are more than 1111, some experts in the field recommend doing GLS automatically on all of them. What was your feeling about it, and what do you guys do in London Health Science Centre?
Yeah, so it's a Kingston Health Sciences Center, but
Oh,
that's okay. So the GLS, I really think it's useful. And this question is timely because we are working as a group here at Queen's to try and streamline echoes for specific indications, and heart failure is one of them. And part of that, and also cardio-oncology, we want to incorporate strain in there. It is, like you said, it's a team sport, so we're trying to get everyone together and the sonographers as well. I have seen this practice done, I think, in Vancouver when I was training at St. Paul's. They had this approach where if your wall is more than 12 or 12 or more, you get strain. They also look at amyloid in their atrial fibrillation patients as well. So we do. I do think that strain is beneficial, and that having it in a systematic way is very important.